We have like 10 or 15 minutes for Q&A. And I think I'm actually going to start with you, Colleen, and ask you, are you available 24/7 to all your patients? And what is happening to systematize and routinize the quality and access to care that you provide to Vicky?
Yes. Is that better? Is that better? There's 2 points that came to mind when Vicki and David were talking. One is, as we move into the community, your virtual healthcare team is so intricately interconnected. You know what Vicki didn't tell you when she was diagnosed with mesothelioma? It was in the early stages of mesothelioma, and the specialists, from their vantage point, saw different solutions. So the surgeon saw cut it out, cut it out, cut it out. The pulmonologist said, I've done her test. She will be a respiratory invalid. She will probably live bed to chair and be oxygen dependent. My role in the case was to give her time to process and facilitate what it would look like to actually live through these decisions. And from that, Vicki decided not to do surgery because she didn't want to live oxygen dependent in her home. But it also meant that my understanding was, because it was early in her phase, she had time to live. So the disease, all of a sudden, which used to kind of frame our myopic view of what was happening, changes as we become more community-based and more interconnected with the subspecialists and with the patient's quality of life goals. The other thing about breaking down those barriers and breaking down those walls, in Vicki's eyes, I am the iconic face of her palliative care team. Redistribution of those resources of how we used to spend healthcare has to change. The amount of resources that goes into making an infrastructure, so we have a 24/7 someone always answering the phone that understands the story, or I can access the story if my colleague or someone else has seen the patient. In Vicki's case, she spends half her year in Florida and half her year in Michigan. The invisible connection of her team is when she leaves on May 5 from Florida, where I take care of her, I will be connecting with her palliative care and our oncologist over in Michigan and handing that off to them. And in that 29 months, we have cared for things. She had pneumonia last month. We got an early start on that, so she wasn't hospitalized. She had some anxiety at some point. We thought maybe her fluid was coming back. Our oncologist immediately got contacted, and they did a scan to be sure that that was not happening. When she goes back, they're actually going to check her pericardium for some fluid. Because we're proactive, in 29 months, she has never been hospitalized. But we haven't gone to an all or nothing with her care. So we have an infrastructure where people are on call and take call, but in how it should be in Vicki's eyes, she sees none of that. She just knows she has access all the time to us. So again, that care is not reimbursed. The phone calls are not reimbursed. The way we do from episodic care to longitudinal care, we have to change the way we redistribute this money. And believe me, the money's just being, we have the money, we just are using it in the wrong way places.
Exactly the point. So we would love to have questions from the audience. If you have a question, please use the mic. There's one over there, and there's one over there. And feel free.
Hi, I'm Jeff Cohen from Common Practice in Philadelphia. I heard, or one of the slides said, going from asking what's the matter with me to asking what matters to me. So can you speak a little bit of how you're systemizing actually learning that important information about your members' patients? Thanks.
Try to make this work. Thank you for that great question. It is very much based on personal preference, and from teaching of even our medical students to start off with tell me what matters most, using Toby Campbell's best case, worst case paradigm for surgical decision making, which is grounded in tell me what matters now, is reinforcing this over and over through education, modeling, and mentoring. That it all starts off with what is important to this person, and that is the hallmark of palliative care.
Hi, this is Joanne Lynn from Altarum Institute Center for Elder Care and Advanced Illness. Martha, I wonder if you could reflect a minute on, I understand the politics of it. Believe me, I understand the politics of it. But what is different with your model called palliative care from the exact same, well, almost the exact same things titled geriatric care or comprehensive primary care? Commitment for 24/7, continuity across all settings, promise to stay with the person to the end of life. If you look around, the only system that regularly does that is PACE, which is a geriatric program. And maybe a little bit as different from palliative care, geriatrics teaches rehab and curative medicine when it's appropriate. I mean, it's not mainly goal discertainment or clarification and symptom management, but includes a somewhat broader range and therefore is much more difficult. And of course, politically is losing ground, and we can't train any geriatricians anymore and all that sort of thing. But what do you see as different?
Thanks, Joanne. So I will hearken to the misty-eyed morning staff meeting at Northwestern back about 1991, 92, where Dr. Charles von Gunten said, what we're going to do this year is become a medical subspecialty. That was a lofty goal. The purpose of becoming a medical subspecialty was to infiltrate medical training, was to raise all boats. When you're a medical subspecialty, you get to, every medical student, irrespective of where they'll go, has to spend time with you. The idea behind palliative care since its inception was not to be a standalone, but was to infuse the competencies of whole person care into every aspect of medical care. So in reflecting on this, we have done specialty training and we've created specialists with a primary goal, I think, of modeling and mentoring and educating and infiltrating and changing medical care. It's one of the reasons we're here today. Is this impact on our health system is much needed. We dissolved ourselves down to a biomedical model, and that is far from our roots. Whether we're geriatricians, whether we're neurosurgeons, primary care internists, these competencies apply to every one of us. And the expression of them and the integration of them is what we have to see. That's why palliative care came into existence.
I would just add to that, Joanne, you obviously know this, is not everyone with serious illness is over 65. And while certainly it's the majority of the individuals numerically, and perhaps the majority of the spend, we need to have these skills and this whole person approach available to anyone, regardless of age or stage or disease or prognosis, not just to older people. So both are necessary. Clearly, it's not either or.
Thank you, Diane. Vicki, I want to thank you for your bravery. You told your story so eloquently and so beautifully, and your points came across so loud and clear. It's a great framing for the day, so I just thank you for that gift. My name's Amy Berman. I'm a senior program officer at the John A. Hartford Foundation in New York City. I'm also a nurse, and I'm also seriously ill, and I also appreciate what palliative care does for me. My question is, there are people out there who are scared of the term palliative care. They don't understand what it means. What would you say to them?
Well, at first I was afraid too. I think what I would say is that at some point you need to put your trust somewhere. And if you're lucky enough to have a palliative care team, at least give them a chance. Talk to them, they'll listen, and they don't force you to make decisions. It took me a long time to come to the point where I was willing to trust that they had my best interest at heart. And that is so important for the patient to know that the team that's caring for them, you're not just a bunch of papers, you're not just something on a computer, but you live and breathe, and they want what's best for you. So I think I have been so fortunate in my palliative care team, both in Florida and in Michigan. I don't know if that answers your question or not, but that's what I would tell somebody.
Thank you.
I would like to add something to that for those who are listening that are in palliative care. I think we have to be sure we keep up with the nuances and changes in healthcare, because when patients trust us to not be one of the voices that have an agenda to maybe not do a treatment or not do that, then maybe we shouldn't be the voice in that team. So again, I would encourage the palliative care team also to understand that there are complex solutions to complex illness nowadays, and we need to make sure we keep up.
One other thing I'd like to add, and I should have told it in my story, is that I have never received any treatment. No chemotherapy, no radiation, nothing. My care has been strictly driven by my palliative care team. And they shared with me my options, but they didn't push me to make a decision. They said the decision is yours, because chemotherapy wasn't going to change my diagnosis. And we know there's no cure. And so I could either do chemo, do radiation, live through those horrible consequences, side effects, or I could choose to do what I did. And what I did was I chose to just live my life.
Seems to have paid off. Here you are, teaching us. I'm just going to ask one more question with the moderator's prerogative. And Stacy, I was really interested in your health system's decision to separate out the innovation engine from the mainstream machinery of the health system, and wonder if that's, has anybody else done that you know of, and how is it working, and what led to that decision?
So I think that what led to that decision was an understanding that we as a health organization didn't really know how to do population health in terms of a value-based approach. And so I think that Banner has become very sensitive to that and to a desire to really provide high-level care for the, I think now up to 30% of risk-based contracts that we are responsible for. So they recognized that they needed to do something drastic and different. I'm not aware of whether or not others are doing something like the Imagine concept across the country, but we are really at the beginning stages of this process, trying to hire team members for the different Imaginariums, and they all span all of the areas that I think are going to be crucial to doing this well, the digital Imaginarium, and so that patients can access the system from the location they want, at the time they want, in the situation they want. The leadership Imaginarium, so rapidly simplifying the decision-making process so it doesn't take a month or 2 months to make a decision. All of these things have to do with moving towards innovation and improving satisfaction. So we're at the beginning of that journey. We're just starting. None of them are up and running yet. And, we'll come back and give feedback on how we're doing.
There's a lot of managed care in the areas around Banner, and not all of it is Medicare. So that a huge part of the driver towards value, regardless of what happens in the current administration, is being driven by the rest, by states and Medicaid, and by the insurance companies. So when people ask me, is value going away? I always say, no, it is not going away, because the rest of the health system is, by necessity, frankly, committed to it. Reading about the Massachusetts Medicaid ACOs and the quotes from the people who are adopting this model is over and over, if we don't do this, the system will implode. We have to do it. And so value is not going away.
I just want to say one thing in reference to your question, Mark, about the community, and to highlight what Joanne so skillfully asking the great question, as Stacy said. It's about the questions, right? It's about how do we do this, and recognizing that it isn't one answer, but it is the coming together of these resources and collaborating and recognizing the competencies that are held together, that are consistent, irrespective of whatever label we have on our name tag. But this is our opportunity, and what an opportunity we have.
It's the wind in our sails, actually. So please join me, everyone, in thanking all of our panelists. And will you guys be around for the rest of the day? You're not staying. All right. Well, have a safe trip. And again, our deepest appreciation and thanks.